Good afternoon, ladies and gentlemen. After a liberal dose of peripheral interventions, this might be a welcome change. We are going to talk about coronary interventions, their complications, their management and prevention, particularly the prevention part. Let's start with coronary perforations. This is the most feared complication of coronary interventions. It has a very high mortality, and therefore I'm going to talk in details about coronary perforation, and then as the time permits, we'll talk about other complications. This is a very celebrated classification, the Ellis classification. It's from type 1 to type 3. Type 1 coronary perforation is an extranuminal crater here. You can see, and this is without extravasation. Type 2 coronary perforations are pericardial or myocardial blush without contrast jet extravasation. Type 3 perforation is a frank perforation through a 1 millimeter or more perforation aperture there, and you have a jet of contrast jutting out of the coronary artery. This is type 3 perforation. Type 3 perforation spilling type is a so-called fortunate perforation, if you may, because it drains into a cavity and does not normally lead to a pericardial tamponade. Here in this case, there's a perforation of the LAD draining into the left ventricle. It could drain into the coronary sinus, left ventricle, right ventricle, but normally it does not lead to tamponade. Talking about causes of perforation, guide wire, balloon, and rotablator atherectomy. These are the three commonest causes of perforation. Atheroablative procedures do have a high complication rate. Not only the high perforation rate, not only the perforations are more, but type 3 perforations are also more, and this is obviously leading to a higher mortality with this with the atheroablative procedures. One example of rotablator induced perforation here: eccentric plaque in the LAD, very calcified, bud impaction, perforation, tamponade, pericardiocentesis was needed. This is an interesting slide which shows that almost half of the perforations do not lead to tamponade in the cath lab. So tamponade can happen when the patient goes out of the cath lab, and the mortality is almost 50% when tamponade develops. So if you suspect perforation and tamponade, keep the patient under intense observation for at least 12 hours. This is very important because the tamponade may not happen in the cath lab itself. You do an echo, there's a mild pericardial effusion, you don't feel rest assured, and don't send the patient to a normal ward. Send the patient to coronary care unit so that the observation could be done, because the tamponade can definitely develop later on. And the best is to act fast and treat the perforation before tamponade develops. Now, this is an example of out of the cath lab perforation, distal Lcx wire-induced perforation here. Did an echo, there was mild pericardial effusion, no tamponade, but 2 hours later, there was tamponade and pericardiocentesis had to be done. How to diagnose perforation? Well, angiographic, you have blush, jet, coronary sinus compression, increased cardiac silhouette. Echocardiography is the gold standard. You can very nicely see pericardial tamponade or pericardial effusion in the echo. Plus, you have a contrast jutting out of the coronary artery, so both of them together leads to the diagnosis of pericardial effusion and tamponade. Management is don't panic, don't hesitate in seeking help. No awards for being a Hercules in the cath lab. Volumes and isotopes, prolonged balloon inflation, pericardiocentesis, covered stent, embolization like coils, gel foam, platelet infusion, FFP directly into the coronary vessels, surgery. Follow-up echo is very important. Now, an example of covered stent in a perforation here. There's a perforation, you can see the stent already placed near that, inflation of the stent, stent deployment, and the perforation sealed. Again, a peripheral perforation, wire-induced coil occlusion, and the perforation sealed. Now, this is a strange case of LAD occlusion where I was doing retrograde LAD recanalization by classic reverse cart technique. And here in this case, there were multiple perforations, and both coils and covered stents were used. So a retrograde passage of the wire through the collaterals. The left side is diseased, the left main is diseased. Antegrade passage, kissing of the two wires, balloon dilatation for reverse cart technique. Patient became unstable. There's some kind of haziness in the left main, so stenting of the left main first, and then externalization of the wire, balloon dilatation for preparation of the stent placement. So far, so good. But you can see here already perforation happening. This is where the microcatheter was all the time there. And with time, this perforation became massive. So coil occlusion there. But unfortunately, where the balloon was inflated to stop the perforation while the coil was being deployed, there was perforation again. So a second site of perforation, a covered stent placement there, deployment of the covered stent. But unfortunately, by that time, the distal perforation was activated again. So we inflated a balloon here to put in another coil. But unfortunately, the perforation happened here. So this is the third site of perforation. Another covered stent here. Between the first covered stent and the coil, as you can see here, this is the first covered stent, this is the coil. Deployment of the second covered stent, and luckily after that we could salvage the case and we could salvage the patient. Pericardial, mind you, pericardial centesis was not needed, so it is very important to definitely treat the perforation before anything else. So quickly treat the perforation before tamponade develops. This is the most important point. But covered stents have their own problems. They are no panacea. They are very stiff. They may be difficult to deliver. They have a high thrombosis rate, high restenosis rate. They are expensive. You need a large inventory for them. And most important is very calcified lesions may fail to seal with perforation. This is an example where multiple perforations fail to seal the perforation. LED, highly calcified, long segment, rotablator done, distal rotablator, balloon dilatations of the whole length, stenting, conventional stenting, nothing extraordinary about it. And this is where the left main LED stent was being deployed, 3.5 stent. After I was control of the size deployment of the stent there, and a massive perforation. So pericardial centesis done, first covered stent, the perforation did not seal completely. Here you can see some perforation. So high pressure balloon dilatation. Unfortunately, the perforation did not seal with the So second covered stent. Then there was a left main dissection, partially extending into the aorta. So a covered stent into the left main, and then a fourth covered stent here because the perforation did not seal. So a fourth covered stent there. It looked like the perforation is sealed. We sent the patient to the intensive care unit, but 3 hours later, again, there was collection of blood into the pericardial space, and we had to send the patient for urgent surgery. So even multiple covered stent did not prevent pericardial tamponade to develop in a patient with a highly calcified. So sometimes covered stents may also fail. Coils have their own problems. Recanalization of the LED, wire-induced perforation here, coiling, and next day there was a post-PCI myocardial infarction CK elevation of 2000. Whatever you do, the best way is to do a mechanical treatment by mechanical treatment of perforation by coils or covered stent, but don't give protamine. This could be disastrous for two reasons. One, it can occlude the stent, and second, it can lead to clotting of the blood in the pericardial space, which may then not be amenable to aspiration. One example of how protamine could be disastrous: left main dilatation, then a conventional stenting crush technique of the Lcx, left main dilatation, left main stenting, and a perforation here. So a covered stent did not seal perforation. Pericardiocentesis was done. Second covered stent, high pressure dilatation. And at this point, the covered stent could seal the perforation, but unfortunately, the colleague from the intensive care unit who was attending the case gave glutamine, and 15 minutes later, see the disaster, complete occlusion of the left main. The patient could not be salvaged. So if you really want to have a smooth sailing, best is to sneak away from doing complex cases. But if not, the second option is to avoid perforation. Some pearls to avoid perforation. Important is to confirm the guide wire location if it is in the true lumen in orthogonal views. One very good example of this is this case where you have an LED occlusion, acute myocardial infarction, anterior wall. The wire is clearly out of the artery, but the colleague did not try to confirm it in the lateral view, inflated at the exit point, and a massive perforation. Another very good example of what can happen if the wire lie is not looked at properly, Lcx dilatation, perforation happening here, wire passage, and unfortunately the wire passed into the track which was caused by the perforation. But the colleague, he was, mind you, was a very experienced colleague, but this is lack of concentration. He thought he is in the true lumen. He forgot that this is a track caused by the perforation. So the wire in the perforation track, stenting, dilatation, and a complete disaster there, connection to the pericardial space, a free connection to the pericardial space. So a coil occlusion was attempted. Again, this was out of the vessel. Pericardiocentesis, you can see the catheter lying into the pericardial space. Left main became unstable, so left main dilatation there, stenting, and then we realized the problem. So we thought we should exclude this artery by putting in a covered stent from the Lcx ostium to the marginal artery. That's what we did. This is a covered stent in the marginal artery. We excluded the Lcx and did a kissing technique, and finally we could salvage the case. So it is very important to see the wire position before dilating it with a balloon, otherwise it could be disastrous. Avoid stiffer hydrophilic wires very peripherally into the vessel. This is an anterior wall myocardial infarction, LED occlusion, wire passage too deep into the artery, as you can see here, dilatation and a perforation distally into the LED. So the first thing to do is coil occlusion before anything else. Before the tamponade develops, do a definitive treatment of the perforation, and then do whatever one wants to do. So stenting of the LED, and this is the end result. So the perforation is sealed completely. Avoid overinflation with oversized hardware, LED stenting, LED after the diagonal. So a balloon dilatation.
Dr. Jain, kindly conclude your slides. We're running, it's already past the 12 minutes allotted.
Okay, but I've been allotted 20 minutes. So balloon dilatation, type 2 perforation. Look for guide wire bias in rotablator atherectomies. So ostial diagonal rotablator. This is a guide wire bias. Clearly, it's an eccentric stenosis and a perforation there. So a covered stent, and this is the end result. So it is very important to do a definitive treatment, a mechanical treatment by covered stent or coil or whatever before tamponade develops. When a perforation happens, paradoxically, the balloon which causes perforation is the best to seal it. So anterior infarction, dilatation, post-dilatation after stenting, and a massive perforation. So the same balloon which caused a perforation is the best to seal it proximal to the stent, dilatation for 10 minutes, and the perforation sealed. Avoid putting conventional stent immediately after you see a perforation after balloon dilatation. So intermediate type 2 perforation here, a conventional stent, and the perforation became massive. So avoid putting in a conventional stent. Best is to wait or put in a covered stent. And never be assured by prior stenting. Perforation can happen through multiple layers of stent. This is the case previous to the index case, which I'm going to show you quickly. Dilatations, stenting, and this stent near the septal perforator. There are 2 stent layers already. As you can see here, this is the end result of the first case. Now, presentation again, few months later with instant restenosis, angina. You can see instant restenosis. So, conventional high pressure balloon dilatation, but the result was not satisfactory. So, a third stent. There are already 2 stent layers. A stent was put within the 2 stents. Stent dilatation, post-stent dilatation, and a massive perforation. So this perforation could occur despite 3 layers of stent. So don't be assured by multiple layers of stent. Don't be too aggressive in dilatation. Perforations can still happen through multiple layers of stent. Graft anastomosis may be particularly vulnerable to perforations. This is an Lcx occlusion here. The graft to Lcx is occluded. So retrograde recanalization of the first the graft recanalization and then a retrograde recanalization of the Lcx. So we attempted the entry of the wire passage and entry retrogradely. Finally, we could have the access to the Lcx. As you can see here, anastomotic point is still not dilated properly. Aggressive dilatation of the anastomotic point and a massive perforation, as you will see here. So covered stents and then a conventional proximal stenting, and the result was good. Microcatheters in antegrade CTO recanalizations wire can induce perforations. They are normally not so dangerous. As you can see here, recanalization attempted. The wire seems to have gone into the true lumen, but unfortunately, no, it wasn't. And you see a perforation. So balloon dilatation and perforation sealed after 5 minutes, continuation, and then recanalization of the Lcx and stenting. And this is the end result. Not only the coronaries can perforate, in the era of tower, even the LVs can perforate. This is an example of straight pteromo causing a perforation of the left ventricle. So be very cautious, don't push the straight pteromo too deep into the left ventricle. Again, a perforation of the LV, as you can see here. After perforations, let's talk about dissections. NHLBI grades of dissection. Type A dissection, you have radiolucent haziness here. This is type A dissection. Type B dissection, you have a parallel tract. Here, it's known as type B dissection. Type C dissection is where you have an extraluminal cap. This is a type D spiral dissection. And type E is new persistent filling defect, as you can see here. Type F is any dissection which leads to impair or occlusion of the artery or impair flow. So there's no flow. This is type F dissection. Mechanisms: plaque fracture, guide catheter trauma, balloon rupture. The risk factors for ischemic complications. This is most important. When should you treat a dissection? So a dissection length more than 15 millimeters, type C to type F, residual stenosis more than 30%, cross-sectional area less than 2 millimeters, transient in-cap occlusion, unstable angina and CTO. Predictors: calcified lesions, eccentric lesions, long lesions, diffuse disease. As dissections after the stenting do not have any bearing most of the time, all tears are healed. So these edge dissections should not be treated unless you have the risk factors, as I told you before, for occlusion of the artery. not only the coronary arteries can dissect, retrograde aortic dissections can happen, like in this case, severely diseased vessel dilatation and a retrograde aortic dissection. Unfortunately, the operator kept on injecting. You can see free flow of the contrast into the subintimal space of the aorta. You can see the aortic dissection. You can see an aortic regurgitation happening, acute AR, aortic dissection there. So if you have aortic dissection, retrograde aortic dissection, how to manage it? Do not inject, early stenting, covered stent, hemodynamic stability and instability, ST elevation in the contralateral territory, tamponade, acute AR, length more than 40 millimeters. Send the patient for urgent surgery. Do not meddle with the patient. Follow-up TE is very important. And prevention, take a guide catheter with side holes, less aggressive guide catheters like JR, and minimal hardware manipulation. This is an example of preemptive stenting of the ostium when perforation when retrograde aortic dissection happens. So the aortic dissection is about to happen here. Stenting of the ostium, then do whatever you like, and this is then the end result, the perforation. The retrograde aortic dissection could be arrested. Another example of preemptive stenting, left main dissection, as you can see here, leading to retrograde aortic dissection, stenting of the ostium, and then after high pressure dilatation, we could do the LAD, and this is the end result. So the third or the fourth complication that can happen is abrupt vessel closure. Quickly going through it, abrupt closure, the treatment is stent in most of the cases. This is an example of abrupt closure after balloon dilatation, the vessel occluded, stenting, and it was all right. Factors associated with abrupt closure, the unstable angina, females, AMI, intranumeral thrombus, angulation more than 45 degrees and a higher AJ score. Predictors of mortality, obviously the percentage of myocardium at risk, left vein and multi-vessel disease. Stenting is the ultimate therapy. This is an example where abrupt closure happened twice. Stenting of the RCA, abrupt closure in the due to proximal dissection, stenting. It was all right. 20 minutes later, abrupt closure in the mid segment, distal to the stent, multiple dilatations and stenting, quickly going through it. And the case was salvaged, and this is the end result. Hardware entrapment, embolization, peripheral complications next year. Thank you very much.
Exhaustive and extensive, and it's very, very important for the newcomers, and a lot of young interventional cardiologists who are watching you. Must be more than 4,000 or 5,000 right now. And this is where they need to learn how to preempt problems, and when you get into problems, how to arrest them and act fast, otherwise they lose the patient and learn it the hard way. So thank you so much, and we move to, we'll have discussion in the end. We move to the next talk. It is by Dr. Ivo Petrov from Bulgaria, and he's going to be talking about resurrection of renal denervation based on latest trial results. And Dr. Jain, I want you to be there because this technology, I believe, was originally started in Germany, and it had a lot of proponents, especially Dr. Horst Sievert is one of the big proponents of this technology and this way of therapy for renal denervation for hypertension. And it went into some problems because of the Medtronic catheter, but it's coming back again, and we have no better person than Dr. Ivo Petrov, who is the president of the Bulgarian Society of Cardiology, to actually speak about it. Dr. Petrov.